You guys got me now? Okay. So we're going to talk about two things today. One is a paper that we've recently submitted to one of the national meetings, and it has to do with platelet mapping in patients who've been on dual antiplatelet therapy. And the other is kind of an update on the talk that we gave last year that we're submitting to other places too, where we broke down the patients by both cabbage valve and complex cases. But so we're going to, like I said, we're going to talk about platelet mapping and transfusion. The people at the bottom of this list are the people besides myself who are ultimately responsible for all of this work. And we have quite a crew. We have Kevin Fleming and Nate Bobalski as our senior perfusionists. Mike Keeney is one of our physician assistants who also has a PhD. And the den mother of the entire group is Roberta Redfern, who was a PhD, and she kind of keeps us all going. As stated earlier, this is sponsored by Haemonetics. This is a picture of our new hospital system here on the left, a new 13-story, 800-bed tower. These are my disclosures. So I just want to go back a little bit and talk about our timeline here. You know, we started our initial investigations into TEG and ROTEM back in 2009, and we actually purchased the TEG products in 2010 and did about 6 months or a year of shakedown and learning and figuring out how to best do this. We then developed full clinical implementation in January of 2011 and have continued that full implementation to date. We've done over 21,000 TEGs. We've done over almost 2,500 platelet mappings. The vast majority of these have been in cardiac surgery, but the neurosurgeons and the trauma surgeons are also starting to pick up on the value of TEG and have been using it more and more recently. So what is TEG? For those of you not familiar with it, it's basically, it's a point of care device. It's called a thromboelastograph. It measures the formation of a clot and gives you an assessment, a global assessment of coagulation. It identifies risks of bleeding, thrombosis, and fibrinolysis, and it identifies and quantifies the need for specific individual blood component therapy, which is as opposed to the shotgun therapy that we used in 2008 and 9. If a patient was bleeding, they got 2 FFP, 10 platelets, and 10 cryo. It also is we use it right in the operating room. It's right in our pump room, which is between our 3 cardiac surgery ORs, and go from there. Now, the platelet mapping assay is a little different. It basically it takes away the limitations of thromboelastography and truly looks at how the platelets are working and the effect of different drugs on the clot formation and the strength of the platelet contribution to the overall clot strength. So basically, the TEG platelet mapping measures how platelet function is responding to their antiplatelet therapy, what is the overall effect on coagulation, and perhaps more importantly for the surgeons, what's the risk of bleeding during surgery? And these are the things that we get. And our threshold, I have a partner who uses platelet mapping on every single cardiac surgery patient, regardless of what they did. And he's occasionally surprised by having a patient that's 100% inhibited with either aspirin only or nothing. And he's canceled a lot of cases because of that. So the technique is a little bit complicated. Essentially, it works by 4 separate assays. And the first one measures the MA, and that's the top gray line here. And essentially, it does is it's a kaolin activated thing. It basically gets rid of all the fibrinogen, the thrombin, and gives us the MA thrombin. The second assay blocks all the thrombin and basically gives you what's from the fibrin only, and that's the lower red one. And then we run 2 separate assays, the MAADP and then the MAAA. And the MAADP is specific for, say, things like with Plavix and clopidogrel, so that the thyropyridines, which block or inhibit platelet function. So we get these curves, and then basically the MAADP gives us a number, and we'll talk about that in a second. But from this number, we're able to determine specifically what values, what we like with regards to what we think is safe. You can also get a percentage inhibition, which can vary depending upon hypercoagulable states and hypocoagulable states. And so really the number that we put the most value in is the MAADP, specifically with Plavix. So this study evaluated the effects of thromboelastography platelet mapping on the timing of surgical intervention in patients with dual antiplatelet therapy undergoing urgent coronary bypass surgery. Dual antiplatelet therapy is very common. Patients who've had stents in, patients who have unstable angina, and there was a time when patients were loaded with Plavix in the emergency rooms for acute coronary syndromes. The doses of aspirin and Plavix range from 75 milligrams to 325 milligrams for aspirin, and 75 and a loading dose of 600 for Plavix. The impact of these drugs is for the most part irreversible, and it takes 5 to 7 days for them to reverse. And it's been recommended specifically for Plavix, there's a minimum of a 5-day waiting period for discontinuation prior to surgery without any kind of qualitative or quantitative evaluation. It's also been estimated that individual responses to Plavix, that 30% of patients are quote unquote non-responders. And yet this is the most common drug used in specifically coronary stenting. So this was a retrospective review of approximately 7 years of patients treated with dual antiplatelet therapy prior to isolated urgent coronary bypass surgery. And the platelet mapping was used preoperatively to determine platelet function and inhibition. Urgent is defined as a need for an NSTEMI, unstable angina, or critical coronary anatomy. This is not patients who were emergent, patients who came in who were, so to speak, crashing and burning and needed emergent surgery on dual antiplatelet therapy. These were patients where we had some time, for the most part, to measure their MAADP and do their platelet mapping, cool them off, and things like that. It consisted of 4 surgeons at 2 institutions. There were the same 7 perfusionists, and basically the TEG 5000 was used to perform the procedures at all patients. Characteristics we got were length of stay, complications, reoperation, blood product use, and these were evaluated as a function of the discontinuation, specifically of the Plavix. Aspirin was continued the whole time. So there were 226 patients which we found eligible for inclusion. Approximately 70%, or 152 patients, had an initial MAADP of greater than 50 millimeters. And we felt these patients were able to undergo coronary bypass surgery sooner than 5 days after the discontinuation of Plavix. There was another 64 patients, or 30%, who had MAADPs less than 50, and these were the patients that we waited on. Now, it isn't just a simple number of 50 or what have you, but 50 was kind of our baseline, and that's when we feel safe recommending it. Perhaps more importantly is what happens in a serial fashion. These patients oftentimes got multiple tags on a daily basis, and we were looking to see improvement in the MAADP and to some degree also the percentage of inhibition. There also entered into this factor certain specific patient clinical indications. If a patient that was relatively stable on day 2 or 3 became completely unstable, then they went to surgery, and we counted those as urgent still because we waited on them a number of days. So once TEG identified the patients, platelet mapping identified patients with minimal platelet inhibition, coronary surgery was performed. Preoperative length of stay was reduced by 3.5 days by looking at platelet mapping as opposed to waiting the standard day. And the total hospital stay was reduced by a total of 3.61 days. Again, all of that captures into the first 3 days, the first 3.5 days that we started with. And so this was a dramatic way of evaluating this and really kind of showed us a lot of things that we didn't know before. And it's clearly become our standard of care to map these patients now as a reflex. So when we looked at this in terms of hospital costs, 226 patients, we saved 816 patient days, a conservative estimate of $750 per day of hospital costs, which is extremely conservative. We figure that we saved somewhere around $600,000 just in this cohort of patients. Again, before you know it, nickels turn into hundreds of thousands of dollars. So there was no difference in perioperative complications, renal failure, stroke, prolonged ventilation, things of that nature. There was no difference in perioperative blood product administration. These patients got the same amount of blood as patients who were not, who were on just aspirin alone and weren't urgent and part of the group. They were matched. There was reoperation for bleeding occurred in 5 patients, which was 2.2%, which is below the national average for bleeding. 3 of them were for actual surgical bleeding, and 2 of them for coagulopathic bleeding, where no actual surgical site was found. So we were, again, it wasn't like we took these patients early. We had a lot of coagulopathies as a consequence of the platelet congestion and going early. So we felt that the platelet mapping could guide the individual patient wait times after discontinuation of dual antiplatelet therapy prior to coronary surgery. More than 66% of urgent patients, CABG patients, were able to go to surgery sooner than standard recommendations without impacting complications, perioperative bleeding, or transfusions. And then tailoring the surgical wait times based upon TEG platelet mapping reduced perioperative length of stay and positively impacted, hospital costs. So, if I may, this study wasn't specifically designed to evaluate this, but one of the questions that we've kind of thought in our own mind is the rate of non-responders to Plavix greater than the accepted 30% rate? I want to stop here. I want to see if there's any questions from the moderators, and then we'll go on to the second half, or just want me to go ahead and proceed?
Got one question. Do you basically do a TEG platelet mapping on aspirin on most of your patients if they've been on aspirin, or do you not? Because aspirin is kind of routine. We never saw a big difference in aspirin use.
Yeah. 3 of my 4 partners do not. My one partner, like I said, he platelet maps every heart, but he's an incredibly conservative he's an incredibly conservative surgeon. So we don't do it. We don't do it for if a patient's just been on aspirin, whether they're a valve or a coronary or even a big complex case. We just do it for patients who've been on, antiplatelet therapy or the factor 10 inhibitors and things like that, just to get a baseline. Okay, we'll go on. So last year we presented a study had about 4,500 patients in it on our TEG experience going from approximately 2012 to 2018. And we've decided to kind of relook at this data and break it up into isolated coronaries, isolated valves, and multiple cardiac procedures. And again, it's the impact of the TEG on what we looked at. So patients were separated into 3 groups: isolated coronaries, isolated valves, and multiple cardiac procedures. We looked at transfusion rates and blood product exposure, re-exploration for bleeding, overall hospital length of stay, morbidity and complications, and then 6-month mortality. So this study was based off of kind of 2 cohorts of patients. 2008 and 2009, we took as our baseline pre-TEG data. And this was approximately 1,049 patients. After full implementation of TEG from 2011 to 2019, we added 4,465 patients. All off-pump cases were excluded, and all 2010 cases were excluded. 2010 was kind of our learning curve year and implementation year, startup year. We did include this time, minimally invasive and also circ-arrest cases. And so here's kind of the breakdown on what we had. Approximately 52% were coronaries, 32% were complex cases, and 16% were isolated valves. So I suspect this is a relatively common mixture among moderate-sized cardiac surgical programs. So when we looked at this, and this is in the coronary group alone, in the pre-TAG unit versus the when TAG was being utilized, our red blood cell usage dropped by practically 2/3. Our FFP and cryo usage dropped literally off the map, and platelet count dropped by approximately half. And again, this is not unexpected because again, this is a very focused transfusion protocol that we used. We didn't shotgun anything anymore. In the valve cases, it was nearly identical, a dramatic reversal. 1/3 approximately of the use of red blood cells, FFP and cryo were gone. Platelets were not quite as dramatic as with the coronaries. And then for multi-procedure cases, these are valve coronaries, double valves, valve arches, circle rest cases. Again, blood loss was about half of what it was preoperatively. FFP was down by literally 75%. Cryo was almost non-existent. And then platelet use was up, but it was still statistically significantly different than it was in the pre-TAG era. So again, our blood product use has been dramatically curtailed, we think, specifically because of TAG. When we looked at transfusion exposure, we looked at it in 2 periods, perioperatively and then in the entire hospital stay. And in the perioperative region, which is the 2 bar graphs on the left, we reduced it, upwards of almost 30%. And in the total perfusion, the total rate of transfusion exposure for the whole hospital stay was again approximately 30% reduction in exposure. So again, dramatic, huge differences case to case. Finally, we looked at the reoperation rate, and in 2008 and 9 pre-TAG, our reoperation rate was approximately 6.1, and at the time, still considered a number that I know of is a reoperation rate for bleeding of approximately 5% is normal. This is all comers. This is complex cases, valves, coronaries. Well, now our number sits at around 2.7, and if you break it down by coronary, our coronary reoperation rate is 1.2. Our valve reoperation rate was approximately 3%, and our multiple complex procedure rate was approximately 3%. But the overall percentage of reoperations is again fallen by nearly 45 to 50%. And this is an important thing both for morbidity and cost, and just making us look like a better program. Period. And we credit or blame TAG for that success. So when we looked at length of stay, we found that patients in the post-TAG era, the TAG era, were basically went home approximately 1.2 days earlier, and that was statistically significant. When we looked at complications like stroke, pulmonary dysfunction, vent times, and renal failure, all improved in the TAG era. And there's multiple factors that accommodate for that. We were unable to prove through multivariate analysis that it was solely a TAG-related function, but TAG did in part was one of the contributing factors to it. Surprisingly, overall 6-month mortality, there was no significant statistical improvement that we've been able to determine yet. We're still looking at this data very carefully and trying to refine it. We were able to prove in complex cases in an earlier paper that a 6-month mortality was significantly improved with the use of TAG, and TAG being the specific factor for that. So a couple of conclusions from this update. TAG provides a global coagulation overview. No question about it. It directs specific blood product component therapy and secondary protamine requirements. Our most common intervention is protamine, additional protamine, and despite what the ACTs tell us. There's two significant keys to success, we feel. One is to have the TAG devices located in the operating room. Having them in a standard lab, remote from the operating room, really dilutes the time that it takes to perform one, or the success of repeat ones, and all that. We just tell our perfusionists, let's run another TAG in 5 minutes or 10 minutes, what have you. And our perfusion staff and the nurses that support them are experts at running it. Finally, you have to have physician buy-in. You know, a lot of these machines have been sold, and unfortunately, they turn into you know, expensive paperweights. But very early, we all bought into the fact that this was a good thing, and more importantly, we saw the success that we had with it. We saw that we gave a unit of platelets, things got better. We gave another 50 milligrams of protamine, things got better. So I think that's clearly a gigantic thing. So we've demonstrated a significant reduction in overall blood transfusions and blood product transfusion exposure, significant reduction in reoperation, length of stay, and morbidity. And, you know, a couple final thoughts. Continued significant improvement since 2011 in transfusion rates, patient blood exposure rates, and reoperation for bleeding. That's over, you know, working on a 10-year period now. And basically, we credit TEG with the vast majority of this, unquestionably. And so when you really come down to it, the only question is why. It's amazing to me that more people aren't using TEG in a similar fashion that we do. I think, you know, we've become cheerleaders for TEG, and unfortunately, a lot of our cheering has occurred under the banner of COVID-19 pandemic, and so I think that's stifled some of it. But unquestionably, I think this is a message that needs to go out to everybody, and the introduction of TEG at major cardiac centers and even minor cardiac centers is probably just as important, and the use of it is not to be debated. Again, one final remark here. Again, I want to specifically thank my co-authors, Dr. Redfern, Mr. Bobalski, Mr. Namey, Mr. Fleming, and Dr. Keeney for the collection, analysis, and writing of all this data. And again, my thanks to Haemonetics and Mr. Curran, and then also to the symposium. It's been an honor again coming back. I keep coming to this seminar virtually. I want to come and go in the sun next year. I want to come next year and we go in the sun. You know, I don't know what I'll be talking about, but I want to come when it's warm sometime. Anyway, thank you all very, very much. I'm happy to take any questions from anybody.
Thank you so much. That was an outstanding presentation. Are there any questions that are coming up on our chat box, Susan, or anybody?
Yes, we have a lot of questions wanting to know if you have a set protocol based on your TEG results, and if you do, could you share it?
The protocol that we use is very analogous to the one that Haemonetics has published previously and have been published. We look at the TEG, we look at the patient. If the patient is dry, unless the TEG results are, and if the TEG results are very abnormal, the first thing we do is repeat the TEG. I mean, you know, sometimes they're just wrong. On the other hand, if the patient is wet, you know, clinically coagulopathic, we look very, very carefully at the TEG and go from there. And you know, if it says we need platelets or we need FFP, or more importantly, most commonly, simply just more protamine, that's the common way to do it. Now, I will say that we also do a preoperative TEG, and we also know what, going into the operating room, I know what the patient's platelet count is. So, you know, if I have a platelet count of a normal in our institution is 150,000, if I have a platelet count that's starting at 110,000, for the most part, we're ordering platelets before we even come off bypass, because we know we're going to be probably less than 50,000 coming off. And the TEG will oftentimes be markedly abnormal. And oftentimes we've gotten to the point now where we just start the platelets and then wait for the platelets to go in and then do the TEG. And even then, we still find that the MA is significantly diminished. What we also find sometimes is also that the Rs are significantly longer than they should be, and that again, more protamine is necessary. So it's a to and fro thing. Again, the probably the biggest thing that you want to make sure of is that you want to do serial tags. You don't want to just base your entire therapy on just the tag that occurs 15 minutes after protamine's in. You start that way, and if you've given more protamine, patients can look good, and then they can have rebound and require significant doses of protamine, especially the obese patients, the fluffier patients. And then so you've gotten a second tag cooking, usually within half an hour of the first. And then when they go to the ICU, we get repeat ones. Anybody that bleeds more than 150 cc's in the first hour in the unit gets a second tag right then and there. So there's really not a hard and fast rule that we use, but we're meticulous about it and we're compulsive about it, and we keep following these patients very carefully. I hope that's answered your question. It's a long-winded explanation. I apologize.
Thank you.
How about the use of other pharmacologic? I mean, we use a lot of DD-ADPs and found a huge, basically pharmacologic approach using the TEG and the use of that product in the post-operative setting.
We have used DD-ABP relatively sparingly. Probably should be using it more though, and we don't. And for the most part, and I don't know the numbers would say that 60% of our patients don't get any blood products. 60-70% of our patients don't get any blood products. So and the ones that do, most of the time, it's obvious they need something. So we kind of tend to jump over DD-AVP and either go right to transfusion after we've had an abnormal tag.
Yeah, we saw that when we used it, the tags came back to normal. So therefore, we didn't use any blood product during that period of time.
Like I said, we probably should be using it more commonly. I agree.
Dr. Moront, a lot of questions have come up about, have you done a cost basis evaluation on utilizing TEG technology and the use of blood products, or the savings that you have, your hospital, or your institution has made because of minimizing blood transfusion product?
We actually have, and we presented some of that data last year here. But essentially, when we looked at the analysis was initially based on what we called complex cases. These were multiple procedures: valve coronaries, double valves, valve arches, things of that. At least 2 procedures. When we looked at this cohort, and there were approximately 350 patients in the pre-TAG era versus the post-TAG era for the first 2 years when we started, we felt that we saved approximately $4,000 a case in transfusion. And if you ramp, and that didn't count length of stay, it didn't count the reoperation. This was just in blood acquisition costs, which are real dollars. They're not, hospital costs. These are real dollars. This is what the hospital pays to the Red Cross for the blood products. When we went and extrapolated out the whole series, the 5,000 plus patients that we have now in our database, 5,500 patients, and you looked at, again, blood acquisition costs, and this is still a little bit of a fuzzy number, length of stay, return to the operating room for reoperation, and things of that nature. We felt that we've probably saved our institution over the last 9 years $45 million in costs. And again, we credit TAG with the vast majority of that. It's huge how much we think we've saved. And quite frankly, our hospital administrators, they struggle with that number, but they understand that number. And there's charges and there's costs, and costs are approximately 20% of charges. That's a kind of a ballpark number that's a fair number to use. So we feel that we've saved, tens of millions of dollars over the last 10 years. Never mind quality. Quality is a separate issue. But as far as just pure costs, $45 million.
So that segues into my question that others have asked on our QA side, is that I can see where if you present those numbers to hospital management, they're going to jump right on it. but sometimes, and I think physicians might if they're in charge of that. But sometimes people are asking, how do you buy in? How do you get a surgeon or an anesthesiologist to buy into this? Obviously, you say there's improved quality, and I believe that. So that's their interest. But how do you get an institution to buy into that, where the physicians are actually utilizing the technology to gain this kind of positive impact on the patient load?
Well, I think sometimes going back, over 10 years ago when we first started TEG and brought it into the hospital, it was a little bit, if pardon my language, a little bit of a pissing match between the lab. The lab wanted this. They looked at this as a moneymaker, and they wanted it, 3 buildings away. In fact, now our lab is actually off-site. It's not even in the same building, and specimens have to get in a car or a tube and go 3 blocks away. So that was number one. That's battle number one. Battle number two is, I think you have to start small, and you have to have your perfusionists really up to date. I was personally involved in the selection of the Haemonetics TEG system back in 2010. I went to the meetings, I listened to the data, and I said, we got to try this. And being one of the busier of the 5 surgeons here, I was a fan of it. And, it was a learning curve for all of us, the perfusionists, myself, my partners. But, over the course of 6 months in, say, 2010, it gained traction. And we recognized that, patients who, quote unquote, had a normal ACT could still need more protamine. And that was the first thing right there. And then you start, recognizing that we're not given, when you have a patient that, was a little bit wet and they got, 2 units of FFP, 10 units of platelets, and 10 units of cryo as a shotgun approach, as opposed to 1 unit of FFP or 1 unit of platelets. They didn't gain 4 kilos of weight and all that. And patients just did better, pulmonary wise, volume wise, things of that nature. So once it got started, it was relatively easy to transition and get this going. The hospital lab, we kind of fought it because our TEG 5000s are still located in our perfusion room, like I said, adjacent to all 3 or 4 of our cardiac ORs. And I think that's a critical thing. You can't have this thing in a lab, 3 buildings removed, and there's got to be some urgency to it. And again, it's not just one TEG; it's a series of TEGs that we perform on a patient who is, wet or bleeding or what have you. That's important.
And what we found is, Bill, and to answer that question too, is by setting up a blood management program and bringing a speaker in, such as Dr. Spies or Dr. Moront, into an institution to basically have face-to-face contact with our surgeons, that was something that inspired the use of the TEG program. So, I think you got to have the experts come and talk. Sometimes they don't listen to just us when we're speaking. So it's always nice to have a surgeon on board.
And the other thing too is I think it's not just surgeons that speak the speak and walk the walk, but I think in places where they're serious about starting it, having a perfusionist go in and help them with the first, I'm going to say week of TEGs, and not necessarily having the surgeon there for all of it, but maybe for a day or two, looking over the drapes with the other surgeons and saying, this patient just eyeballing, this patient looks a little wet to me, or looks perfectly dry. And, right now I would just watch the TEG, and go from there. And again, kind of what goes through our head and how we interact with our ICU nurses and things like that. I think that's a critical component of it too.
And when you had that 2.7 true surgical bleeds in your slide presentation, you could actually tell when you had a normal coagulation with a TEG, that those patients most likely could go directly back because it was a surgical bleed if you have that much output, correct?
Yeah, is it perfect? No. Much like our platelet mapping study, where there were 5 patients taken black for bleeding, 2 were for coagulopathy, 3 were for surgical bleeding. You know, it's a little bit of a crapshoot. I think what we don't find now is, you know, where something like 60 or 70%, we go back and find nothing, just coagulopathy that's it's either resolved and we've taken them back because their chest tubes have clotted and there maybe have some tamponade. We don't see that anywhere near as much as we used to. It's just nothing more frustrating. You make a patient dry, you take them to the ICU, and the first hour they have 500 cc's, and you watch them for another few hours, and you give them the platelets and protamine and everything else, and you take them back. The operating room, you find nothing, and that was kind of a common theme that we'd see. Excuse me, back in 2008, 9, and 10, before we really had the TEG. Now we're able to specifically isolate what factors are required. And oftentimes, again, our most common intervention is just simply more protamine.
Any more questions from the Carla or anybody?
Yes. One more question. Ryan D would like to know, do you use an HMS for your heparin and protamine doses? If not, what is your protocol?
Our actual protocol, we have actually looked at the HMS, and we've done some work with Medtronic on the HMS. It's a fascinating device. We kind of find that we're kind of splitting the difference between the HMS and what our protocol is oftentimes. We've gained some confidence with the HMS. Sometimes the HMS calls for very, very little protamine after an operation. Sometimes it calls for a lot. Routinely, the HMS calls for a lot less protamine than we would routinely give by our protocols. I apologize, I can't give you a milligram per kilo dose. That's my perfusionists that do that offhand, or their protamine dose either. But we've used the same heparin dose and the same protamine dose based upon how much heparin they've gotten for decades. The HMS system, measures the actual heparin dosages and allows you to zero in on exactly how much protamine you need and lets you lose less heparin. So again, it's a fascinating device. I think it's something that, quite frankly, can complement the TEG, and the TEG complements the HMS. That's kind of our view on it. We don't use it routinely though.
Thank you.
I got one more question. Do you do a routine warming tag on cardiopulmonary bypass?
We do not.
Yeah, we do not either.
We do not. We always, first off, we rarely cool anymore, to be honest with you.
Right.
It's the only cases that get cooled are difficult cases or circle rest cases. Those, we're cooling less than 5% of our cases, 10% of our cases. We used to cool routinely to 32 degrees, and we've stopped that, 10 or 12 years ago. We basically give our protamine, wait a good 10 to 15 minutes, draw an ACT and a TEG simultaneously, and we get kind of an instant read on the ACT. If it's significantly off, say by 20 or 30 points, seconds, 20 or 30 seconds, and again, looking at the patient, we would probably give an additional 50 milligrams of protamine, and oftentimes the TEG will either validate that or not validate that. The R's aren't separate. The KLN R's are not separated. But oftentimes the TEG will come, the ACT will come back normal, and the TEG will say, you need more protamine, period. And we see that. So we do not do any kind of a rewarming TEG at all.
Yeah, we found that it was not beneficial. In fact, we would end up giving more blood products if we used it that way, and that's the situation. Because, like you said, 10 to 15 minutes post-protamine, it was a totally different looking TEG than what we found when we were on a rewarming study.
I agree. Yeah. Initially, for the first year or two, just kind of playing around, learning about it, but we rapidly stopped doing it.
Dr. Moront, I think some of the issues that people have had in their institutions is they come off bypass and there's bleeding going on, and let's just assume it's not suture related, and we run a TEG, and in the meantime, before getting that test, there might be a quick draw McDraw that says throw the whole blood product sink at the patient because we don't have time to let the patient bleed further waiting on the TEG. How have you handled that kind of situation so that you can identify the exact products to use to minimize transfusion reactions possibly?
Well, like I said, again, 10 to 15 minutes, the TEG is drawn. Routinely things, the specimen, the R's, this doesn't split, in a good case for, less than 10 minutes. Most of those patients split 7, 8 minutes, some of them even 5 and 6 minutes. But so that gives us a baseline and also gives us a baseline on whether we need more protamine. And then, routinely we have a pretty good handle on what's going on approximately 20 to 25 minutes after the TEG is started on what's going on. Now, at the same time, we're drying up, we're decannulated and all that. We're making sure everything is good. And we're a private practice group, or not private practice, we're a senior group of people. We don't have residents involved. So, we do things fairly efficiently. For the most part, I would say, for me, provided the patient's hemodynamically stable, routinely 45 minutes after we've come off bypass and things are good, and the protamines, I should say 45 minutes after protamines administered and the patient's decannulated, the patient's closed. So during that time, we're sitting there watching the chest tube output, and if it's more than we expect or we thought the patient was very wet, we obviously do a second and a third check of all of our anastomoses. We look at all the bleeding sites. I've been doing this for 28 years. I've got a lot of gray hair, which is slowly falling out. So I know where to look for all these things. And, the expression dry in, dry out helps immensely. I know where all these little bleeding sites can be oftentimes. Rarely am I surprised, that a suture line bleeds or something like that, or something that wasn't bleeding is bleeding, but you just check all this stuff. And then, you just got to be a little bit patient, and being a little bit patient, pays off, because now, they'll sit there, the perfusionist will come back to me and said, it hasn't even split yet and the R is on its way to 14. Immediately we repeat the TEG, immediately, right then and there. And, sometimes we felt that, that, it may have been a bad sample. We felt that some of the custodial cardioplegias kind of put the liver to sleep and delayed the reestablishment of good coagulation. And we're looking at that very carefully. But for the most part, just being patient. And again, 45 minutes from, protamine administration to a skin closure is maybe a little faster than almost all academic institutions, but not all, but not most private practice institutions, I would think.
So David brings up a point on the Q&A, as I was going to as well, that I would have thought that doing a warming TEG on bypass with heparinase would give you an indication that you might have a deficiency in either a factor or platelet function, or give you an idea that if you're bleeding after the case, then the blood bank has already been notified, because in David's case on the Q&A, his blood bank is very slow in getting those products to you. So he's kind of looking at it maybe as an indicator, prognosticating that if there's a bleeding problem, then you know what it might be.
I'll be honest with you, we probably haven't done a rewarming TEG, to my knowledge, for at least 8 or 9 years. So I will say that my recollection and value on that is very distant. Now, I will tell you also that we've learned long ago that if I have a patient that's going to have, say, undergo a big surgery, I routinely have platelets sitting in the platelet. We reserve 4 units of platelets on those patients. And if they're thrombocytopenic, 6 or 8 units of platelets are sitting down there in the blood bank. We can get FFP routinely within 20 minutes, 15 to 20 minutes. Cryo is a little bit more difficult, but the big one is platelets, because oftentimes, we were not a Red Cross transfusion center, so they'd have to send all the way to Detroit. That was basically almost a 2.5, 3 hour delay. So if anything, we kind of over stock platelets to start with, and rarely do we have to go past what we overstock if we anticipate it. So again, we've just not found that to be helpful. But again, it's going back 8 or 10 years since we did it. Maybe we should reevaluate it. Ty, what do you think?
Well, I totally agree. I just felt like like I said, there's other pieces of the puzzle that if you're using the blood management program, I mean, did you do an autologous draw? You're going to be giving that back. What are you doing with your post-operative blood? What's in your pump? How are you handling that? And how are you giving that back to the patient? So again, those are other factors that you don't see in the rewarming phase. So therefore you have to utilize that. So I really don't feel, I personally, when we were doing our study and we were literally down to all comers, with one surgeon down to 4.7% of all his patients ever getting any blood products. It was a huge success. So I just don't find where it's going to be any value whatsoever. It's kind of like doing a platelet mapping on aspirin on every patient that's been on aspirin. Unless you were doing a neuro case, if you were doing some kind of neurosurgery, then I probably would do a platelet mapping with aspirin during that procedure, but not for cardiac surgery. It doesn't really make that much difference. That's my personal opinion, and that's what we found in our studies. The other thing, are you doing an autologous draw off on your patients?
I mean, from the patient itself, yeah.
Okay.
Yeah, it's not from the pump. No, it's
but I mean, at the beginning of the case, you're taking off.
Oh yeah, no, absolutely.
So,
absolutely. We take off. If they have a crit, hematocrit, the threshold is probably around 30, 32, 34.
Correct.
And we try to get some blood off. We work in certain patients, and we probably could do a better job, but patients like witnesses or things like that, I mean, we go wholehearted with them with Epogen and building them up to crits of greater than 45.
Again, utilizing all the puzzle pieces. So that's to me the benefit. The TEG's not a cure-all for everything, but it's one of the best pieces of the puzzle. That's for sure.
Right. It fills in a lot of holes. You're not guessing, and you're not shotgunning.
Dr. Moront, Benjamin had asked if you do a platelet mapping and find that you have a deficiency in activation or deficiency in function, and you offer transfused platelets, how long is it before you do a remapping?
So, I mean, I just want to make sure I understand your question. So if we have we routinely, if a patient comes in, and let's just say the patient's been on Plavix, okay? We stop the Plavix, obviously, and we map them after we're initially consulted for cardiac surgery. And then we kind of do a serial set of platelet mappings. Now, you throw in the weekend in there, you throw in, the fact that Tuesday's my office day, that kind of thing. Those factors enter into it, period, in real life. But more than likely, again, and how sick the patient is. If we're getting a lot of pressure from the cardiologist, or God forbid they have a balloon pump in or something like that, then we tend to go earlier rather than later. But we just kind of go in a serial fashion, and we're looking for improvement. Does that answer your question? I don't know if I'm advanced by.
It does. I guess the question from the audience was, if you're going to figure that you're going to have to give a platelet transfusion to prepare them for surgery at some point, were you doing a remapping after you gave the platelets to find out if you had normalization of coagulation function before you took them to surgery?
We have never, to my knowledge, given platelets preoperatively to normalize a TEG.
We never did either.
Never have done that, to my knowledge. Now if they've got other reasons, if they've got a bleeding groin or from a cath site or what have you, that's a different story. But Never have we tried to correct either thrombocytopenia or platelet dysfunction pre-operatively.
Okay, so basically, just turn the pharmacological agent the like Plavix off, wait that period of time, and then take them to surgery without mapping. Then
Correct. Well, no, they've been mapped.
No, they've been
We
mapped.
map all of them. We map all the Plavix patients. Every one of those gets mapped. So we have some idea where we're starting. You know, sometimes our hand is forced, the patient becomes unstable and cardiogenic shock, we got to go. And, you know, those patients, you know, we know that we're going to give them 2 to 4 units of platelets, most likely, you know, post bypass. On the other hand, if we're able to wait, you know, say a patient that's had significant reduction in their MAADP and significant platelet inhibition, we wait 5 to 7 days in the hospital. The cardiologists are relatively understanding about that as long as they're hemodynamically stable, and we wait them out. Again, what we were able to show in this one study is by doing the TEG platelet mapping that we were able to go much earlier on the vast majority, which was really surprising. Like I said, you wouldn't think that 70% of platelet of Plavix patients could go early, but they did successfully.
Well, Dr. Morant, thank you very much for your presentation.